All right, our second PowerPoint in personal qualities of a healthcare worker involves effective communication. So there are two types of communication. There are verbal and nonverbal types of communication. So verbal, of course, is what we say. Nonverbal is how we say things or our body language. And I'll show you this video. I'll share this video with you, but if something happens, just go to this link, okay? So the communication process, there are 4 parts to the communication process: the sender, the message, the receiver, and feedback. Now, factors affecting communication. Your message has got to be clear. If you are mumbling, like literally mumbling, and people can't physically understand what you're saying, that's one way that we need to be concerned. Another way is maybe the patient doesn't understand your language. Maybe the patient is hard of hearing. Maybe the patient is being distracted. So to make sure that that message is clear, we have to do several different things: avoid interruptions and distractions, make sure that we're speaking loud enough that the patient can hear us, make sure we're speaking in a language that they can understand. So your message has to be clear. Listening. Hearing and listening are 2 different things. I can hear a whole bunch of noise in the background, and that's hearing something, but it does not mean that I'm listening to you. So to be listening, I have to show interest. I'm alert. I'm making eye contact with you. I'm not interrupting you. I'm not thinking about my response while I'm listening to you talk. I need to be empathetic and see things from other people's point of view. I also, when I'm communicating, need to watch my body language. When I'm listening to you, I don't want to just cross my arms and kind of look negative, because that's going to make that person think that I'm not listening or I'm not interested in what they're saying. If I don't understand what you're saying when I'm listening to you, I need to ask questions, ask clarifying questions. I need to have a positive attitude. If you go into something with a negative attitude, you're going to come out with a negative attitude most of the time. So listening is a lot different than just hearing. You have to actually be in that conversation. Nonverbal communication includes your facial expressions, body language, gestures, eye contact, and touch. Now, facial expressions sometimes get us in trouble because you might be listening and don't want to say anything ugly, but your face is like, oh my God, did she really just say that? So we really need to watch what our facial expression says. You've seen little memes that say, if I don't say it, my face will. So we've got to be aware of that, okay? Now, body language. If you're standing with your arms crossed and you're tapping your foot, that lets me know that you're not interested in that conversation, that you're ready to leave, okay? If you won't look at somebody in the eye, I have a big issue with that. People used to say that if you wouldn't look somebody in the eye, you weren't being honest with them. So, just be in the conversation. Listen to what somebody's saying. Have eye contact with that person. Now, touch. When your patient, like if you're discussing things with your patient and you can't really, I'm trying to think of examples. You want to give like a reassuring touch to your patient. I'm not saying go up to them and just, oh my gosh, and hug on them or something. But if you're standing in the room with your patient and they're telling you, some terrible news that they just got from their doctor, sometimes a reassuring touch, just you touching that person's shoulder, is encouragement to that person. Okay. But now you also have to know if that person, is someone who is receptive to touch, because some people don't like their personal space to be invaded. So you really have to be aware of that. Barriers that we can have to communication. We have physical barriers like disabilities. Patients deaf, they're blind, they have some speech impairments, they're unable to convey what they're trying to say. They can have some psychological barriers like attitudes, prejudices, stereotypes. If we are prejudiced against a certain group of people, we're not going to be very receptive to communication with them. Okay, cultural diversity is another barrier. Language difference is a big issue in our community because we have a large Latino population, and we want to be able to reach those patients. If a mom is at the hospital and she's having a baby and she doesn't speak anything but Spanish, I want to make sure that I can communicate with her in some way. But I also want to use good eye contact and touch and reassure her if I cannot communicate with her by her language. Making observations with our sense of sight. We can tell the color of a patient's skin, and you're thinking, yeah, well, everybody can. But what if the patient's skin has a blue haze to it, which is called cyanosis? I need to document that. Their pulse oxygenation may be low. I need to be able to look and see if they're having some swelling, which is called edema. If they have rashes or sores, maybe they're having an allergic reaction to a medication. I need to know the color of their urine and their stool. It could, if their urine or their stool is like coffee colored for their stool, or like an amber color for their urine, it could mean that they have blood in their urine or stool, and we need to address that. We need to be able to look and see how much our patients had to eat. If they're eating well, they're doing pretty good. But if they're not eating, they're not drinking, we need to be concerned about those things. The sense of smell. We need to know not just, you stink, but we need to know certain types of wounds can have certain odors, and that can be indicative of a type of bacteria that may be in that wound. Okay, so we've got to be able to recognize smells. Our sense of touch, we need to feel our patient's pulse. Is that pulse real weak? Is it real strong? Is it thready? Is it irregular? That means their heart rate is irregular. I need to know if their skin is dry and warm, if they're perspiring a lot, if they're real cool and clammy, and again, if they've got swelling. I've got to be able to tell those things about my patient when I'm doing my assessment. My sense of hearing. I need to be able to listen with the stethoscope and listen to their respirations. I need to be able to hear abnormal body sounds if they're gurgling, if they have a lot of respiratory secretions. I need to know that. I need to know if they've got a deep productive cough. I need to be able to tell if their speech is clear. If they're having some slurred speech, I need to be able to recognize that. They may have had a stroke. There are two types of observations when you're talking about charting. There's subjective and objective. Now, subjective is the symptoms that the patient has. Subjective observations cannot be seen. They are statements that are made by the patient, like, I have a headache. I'm nauseated. Okay? You can't see those. You can't measure those. So those are subjective. Okay? You can't measure them. Now, an objective observation is a sign that the patient has, like something that I can see, something that I can measure, like a blood pressure, a temperature, a rash that they may have, a cut that they have on their skin, a bruise that they have. All of those things can be seen. They can be measured. I can actually measure the cut, the rash, the bruise. I can measure all of that. I can see it. So those are considered objective. They are signs that I can measure. Subjective are symptoms. I can't see them. They're things that the patient says. Now, basic rules for recording. And I mean like recording, not like a music video. Recording something in a patient's chart. A lot of this talks about paper charting, but a lot of times we're not even doing paper charting anymore. We're actually doing electronic charting. So the things that I'm charting in that patient's chart should be accurate, they should be concise, and they should be complete. I can't put my opinion in that charting, okay? My opinion doesn't matter. It's got to be neat and legible. If it is written in a patient's paper chart, you need to use correct spelling and grammar, because if that chart for some reason goes to court because maybe the patient sued somebody, you do not want your charting to be in court and like, oh my gosh, they can't even spell words correctly. How are they a nurse? Okay, so you only chart objective observations, like, patient has a 4 centimeter by 2 centimeter rash on the left upper arm. Okay, I can't say patient is nauseated. I can't state that because I don't know that. I can say patient states she is nauseated. Okay, but I can't only chart the things that you can see. Now, if you are going to chart, patient's nauseated, you need to use it in quotes as the patient did actually say that, okay? Always sign your name and your title. And if you by chance make a mistake, this is a test question. Never, ever, ever use whiteout. If you're charting in a patient's chart, you would draw one straight line through the patient, through the error. You would write error above it with your initials. Don't try to hide what you wrote. You can actually write, charted on wrong chart. That's okay because people make mistakes. But don't let it look like you were trying to hide anything in that patient's chart. HIPAA. It is Health Insurance Portability and Accountability Act. And that is just saying every patient deserves privacy. Okay? As a healthcare provider, we are obligated to make sure that we do not repeat anything that we hear or see about a patient. Okay? The patient can see their records, and the patient can control who sees their records. But every healthcare worker has got to protect patient records. Those patients, our patients, need to feel like they can trust the healthcare provider to talk with them, to tell them what's going on with them, without thinking, well, gosh, they're going to go to the grocery store and tell my neighbor, if she sees her, that I've got, whatever. So HIPAA is something that we're going to go over a lot. And if you're in healthcare, whether it's dentistry or psychiatry or nursing or whatever you go in, HIPAA is a big aspect of healthcare, and it just lets you know. And let me give an example. Just say, I am not pregnant, guys, okay, so don't even think that. Just say I go to my doctor and you are in the room next to my room and you hear my doctor talking to me, and they say, well, Amy, we just done a urine test and you're pregnant. Well, I'm like, oh my God, that's crazy. I don't know what in the world I'm going to do. So I'm not going to go home and tell my husband tonight. I've got to think about it. I just got to get my own head wrapped around it. So then if you're in the room next to me and you know that I'm in that room and you hear that provider, that doctor tell me that I'm pregnant, and you know my husband and you see him in the grocery store tonight, it's like, oh, hey, congratulations, I heard Amy was pregnant. You can't do that. I haven't even told my husband yet. So you can't do that. Just because you hear something in a doctor's office or in a dental office or wherever you're working at, you do not have a right to give out that patient information. Okay?